And most recently, at the last TCT, we presented a 5-year follow-up of part of 3 low-risk trial, which again gives us confidence that this is a proper therapy in a broad spectrum of patients that have valvular aortic stenosis. And TAVR has led what we call the structural heart revolution. If we look at the STS-ACC registry, you can see that now there are more TAVRs that were performed than surgery procedures, and that includes surgery with concomitant bypass surgery since 2018, so much so that this year there will be more than 100,000 TAVRs in the United States alone. And we anticipate that the global structural heart disease procedural volume will exceed over 500,000 patients in the next few years. So what I'd like to cover in the next 25 minutes is a new way of thinking of aortic stenosis, so that you consider it not just a disease that requires a treatment at one point in time, but a disease that really is a lifelong journey for the patient. To introduce this upstream conceptual framework, to try to suggest that AS is both underdiagnosed and undertreated, the concept of preemptive or earlier AVR, and then some of the downstream considerations which we think are equally important. Let's begin with this upstream conceptual framework. As you know, the fundamental manuscript in aortic stenosis, helping us to understand the natural history, was written by Ross and Brownwald in 1968, and at the Heart Valve Society, we celebrated with Dr. Brownwald and many other leaders in valvular heart disease the 50-year anniversary of this seminal manuscript. And we asked Dr. Brownwald, what does he think is the most important new investigation that will help us to manage this disease in the future? And he pointed to a manuscript that we had published the previous year in the European Heart Journal, looking at a staging classification system of aortic stenosis based on the extent of cardiac damage. My colleague, one of our previous fellows, Philippe Ginero, was the first author, and this is a manuscript which has helped to guide some of our thinking going forward. We divided patients with aortic stenosis who participated in the PARTNER trial into 5 stages, where we looked at those patients that had varying degrees of cardiac damage. Stage 0, no damage. Stage 1, evidence of either LV hypertrophy, diastolic dysfunction, or systolic dysfunction. Stage 2, progressive to left atrial enlargement, mitral regurgitation, and atrial fibrillation. Stage 3, pulmonary hypertension with now tricuspid involvement. And stage 4 with moderate or severe RV dysfunction. And what we learned was before AVR, in this population of over 1,600 patients, that 85% of these patients already had more than stage 1, stage 2, or greater cardiac damage. So at the point of treatment, these patients already had significant cardiac damage. And if you look at the 1-year mortality after AVR, either surgery or TAVR, we could track the 1-year mortality related to the baseline cardiac damage. If you were stage 0, it was less than 5%. If you were stage 4, it was 5 times higher, 25%. So this again made us think maybe we're waiting too long to treat many of these patients with aortic stenosis. We looked at this further and then looked at 1 year to see what the change in cardiac damage was. And if you were either stage 2, 3, or 4, you could see that with baseline cardiac disease, despite AVR, successful AVR, more than half of the patients had no change or worse cardiac damage at a year. And the change in cardiac damage in a year strongly predicted the clinical course, looking at 2-year death and heart failure rehospitalizations, leading to the hypothesis that in severe AS, simply waiting for symptoms as the main trigger for AVR results in more cardiac damage, which is not reversible in most patients after AVR and predicts long-term adverse clinical outcomes. And this became our working hypothesis. Now, we've been focusing on severe aortic stenosis. I will tell you that moderate aortic stenosis, correctly diagnosed, is not so different than severe aortic stenosis. This is the classic manuscript from Jack in 2019, looking at the Australasia Echo database, indicating that if you look at mortality, either early or 5-year mortality, there is not much difference in the moderate AS patients compared to the severe AS patients. So when we saw this, we immediately worked with our colleagues at the University of Leiden and Jerome Bax and probed their database in patients with moderate aortic stenosis and did the same analysis in over 1,000 patients using the index echocardiograms and divided these patients into 5 categories of cardiac damage. And what we saw was the same thing. We saw that in 60% of patients in moderate AS, many of whom were asymptomatic, they already had at least stage 2 or greater cardiac damage. And if we looked at the 5-year mortality or the 5-year composite endpoint of mortality, stroke, and rehospitalization, we again saw that the baseline cardiac damage predicted later clinical outcomes. So this applies not just to severe aortic stenosis, but moderate aortic stenosis as well. So our belief is that all of these years, from the very beginning, we have largely misunderstood aortic stenosis. And we've really assumed that this is largely a disease of valvular heart disease, resulting in hemodynamic abnormalities at the heart valve level. And the treatment dogma was, well, if the AVA is less than 1, or the peak velocity is greater than 4, that is the trigger in a symptomatic patient for treatment. We now understand there is significant associated cardiac damage during this so-called latent period, and these are 2 parallel processes with variable linkage. So at what AS severity do adverse events occur, like mortality or symptoms or cardiac damage? We believe there's wide patient variability in AS pressure load tolerance and the expression of adverse events. And this is a critical concept which leads to a change in thinking about how to manage these patients. So what is this conceptual framework? We believe that aortic stenosis is a chronic disease, either bicuspid or severe calcific degenerative forms. It is punctuated by various clinical events and cardiac symptoms that we've been discussing. The earlier management, and this includes both diagnosis and treatment, coupled with meticulous follow-up, leads to optimal clinical outcomes. We also believe, and this is for the future, that delaying progression of calcific AS before the onset of symptoms or need for AVR should be an aspirational goal, and one that we are addressing as well. And the clinical research efforts should shift from late-stage reactive AVR to early-stage preemptive AVR and other complementary therapy approaches. And now with the availability of less invasive, low-risk transcatheter technologies, and in the future with more durable heart valves, coupled to enhancements in earlier accessibility and earlier diagnosis, that we have the capacity in the next decade to literally transform AS patient management paradigms. So this is perhaps the most important slide that I will show you. We have focused as proceduralists, as interventionalists, on the index procedure. We try to make the procedure as minimalist and as simple as we can. We try to enhance the technology to improve the technical outcomes. We expand clinical indications by doing a variety of clinical trials. And then we respect the fact that there are patient preferences that must be considered with regard to decision-making. But we have largely ignored some of the upstream concepts, which is improved diagnosis, the use of biomarkers, improved access to care, the concept of preemptive treatment, and also trying to delay the disease itself using pharmacotherapy. And we have equally ignored many of the issues relating to bioprosthetic valve durability, concepts of therapy sequencing in younger patients, the treatment of concomitant cardiovascular disease, and adjunctive pharmacotherapy that can manage some of the non-responders. These are some of the downstream activities after the procedure. And what I am indicating is that we need to have a more global understanding of this disease and consider things before and after the index procedure if we are going to best manage our patients. Now, we can't cover all of these things in the next few minutes, but I'll touch on some of the things that for me are most important. Let's talk for a moment about underdiagnosis and undertreatment. First, we don't know the prevalence of valvular heart disease. There have been very few adequate prevalence studies. They've been selective and they've been a little bit confused. So we decided several years ago we need to redo our understanding of the prevalence, the epidemiology of valvular heart disease. And this is a study which is ongoing, about half enrolled. The principal investigators, David Cohen, were my colleagues. We've been doing this with the Cardiovascular Research Foundation. And this is a modern era epidemiologic prevalence study in valvular heart disease, where we use a survey research center to identify what is the correct population to poll. We use local pharmacies to be able to find patients over the age of 65 who might enroll in studies such as this without known valvular heart disease. We literally go to their homes with sonographers and echocardiography to be able to get echocardiograms, ECGs, and blood works so that we can look at biomarkers and we can look at a biobank assessment. And then we use a deep learning environment from Columbia University to apply some of the algorithms we've developed to be able to see if we can earlier diagnose valvular heart disease. This will give us a truer understanding of the prevalence of various valve lesions, and importantly, many of the other aspects that would lead to making strategic socioeconomic decisions about how to screen in older patients. Now, this business of using AI to screen for valvular heart disease, to me, is fascinating. Some of the earliest work was done at the Mayo Clinic using 12-lead ECGs, the first manuscript, European Heart Journal, in 2021. We were working on this at the same time and have developed a program and published a manuscript last year in JAC 2022, just submitted a late-breaking trial to the ACC, where we've developed a bioinformatics deep learning experience and have looked at over 250,000 electrocardiograms in the broad population of patients at New York Presbyterian Hospital, with two of our young cardiologists and bioinformatics experts, Pierre Elias and Tim Pavaluccio. And what we demonstrated was that we could replicate with enhanced algorithms, not just the ability to detect aortic stenosis, but any left-sided valve lesion, looking at a 12-lead ECG with very good sensitivity and specificity. So that's AS, AR, and MR. And this could be the beginning of helping us to more easily screen for patients and identify those that would be at higher risk for significant valvular heart disease, but could go on to an echocardiogram, even in the absence of symptoms, and at a time that, similar to getting a colonoscopy or getting other screening tests, we could have a better understanding of the prevalence and the importance of valvular heart disease. Now, AI is also being used to actually look at the echocardiograms to identify specific phenotypes of aortic stenosis severity to prioritize therapy. We're all challenged by the economics of being able to manage patients. And if we can identify those that are at greatest risk, then I think we can better prioritize who needs treatment. And this work is progressing very rapidly, and soon we'll be able to identify, just using AI principles and looking at the echocardiogram, those within the severe or moderate category that most need therapy. Next, I want to mention this issue about access to care and utilization and under-treatment. This is a study that was published a year ago, and this is from the two major Harvard hospitals, MGH and Brigham and Women's, and women. It's Sean Lee and Sammy area, looking at over 11,000 patients, more than half of which had an indication for AVR by classical guidelines. Less than 50% of these patients at these two major academic centers actually received AVR despite having guideline class 1 recommendations. And you can see the severity differed, but even in high gradient, normal EF patients, 30% of individuals who, by classical indications, require AVR were not treated, and if you had low flow, low gradient AS, the number was much higher. So, even at the best institutions, we are undertreating significant valvular heart disease. This leads to the concepts of why we believe that preemptive treatment may be an important future therapy for these patients once we diagnose severe aortic stenosis, and at times, as you'll see, moderate aortic stenosis. This began with 2 small surgical series published in New England Journal in Circulation. Again, these were smaller studies looking at early surgery versus conservative care, one in South Korea, one in Europe, both indicating that there was benefit from the standpoint of clinical outcomes if you treated these patients earlier, and in this case it was surgical AVR. Small studies, each one has certain flaws in their analyses, but still gave us a feeling that earlier treatment could have a positive impact. This led us to develop a trial, a concept in 2016. We began enrollment in 2018 called Early TAVR. And this is a massive study of almost 1,000 patients with severe, exercise test confirmed, asymptomatic valvular aortic stenosis, treated with TAVR, and in this case transfemoral TAVR, with a balloon expandable valve, versus clinical surveillance, with a biobank and with core labs and with 10-year planned follow-up. Well, we finished enrollment in this study in December of 2021. And for those of you, and I hope many of you will come to TCT next year, it'll be a landmark year because we have many new exciting trials. This trial will be presented, and depending upon the outcome, this will transform the way we think about asymptomatic severe aortic stenosis. Now, another trial that we hope will be presented at the same TCT meeting is the EVOLVE trial. It's a brilliant study by David Newby and Mark Dweck from the United Kingdom. It's a smaller study, 250 patients. Again, severe asymptomatic aortic stenosis, but using biomarkers and using cardiac MR to screen an at-risk population, and then randomizing to early intervention, either with surgery or TAVR, or with routine medical care. So this will be a fascinating study as well. Now, I've been talking about severe asymptomatic AS. I don't want to lose some of the themes on moderate aortic stenosis. We've been interested in moderate aortic stenosis for about a decade now. This is an interesting study that we participated in, looking at multiple populations of HFrEF, heart failure and reduced ejection fraction, less than 50%. You'll see the black line of those patients with simply HFrEF and no aortic stenosis. 6-year mortality was about 40%, 37%. If you look at HFrEF, and this is a propensity matched series, with moderate aortic stenosis, the blue line, it doubles. The mortality doubles if you add moderate aortic stenosis to HFrEF. Whereas if you treat the moderate aortic stenosis with HFrEF, the mortality goes down to the red line, which is slightly above but dramatically improved compared to the untreated moderate AS patients. And this gave us one of the reasons why we went ahead with a whole variety of studies in moderate aortic stenosis, feeling that we could change the natural history of that disease. This is another trial that should be presented at the next TCT. It's called the TAVR Unload trial. And this is the first upstream moderate AS early treatment study in patients with known heart failure and reduced ejection fraction. It's a 47-center international trial, a 1-to-1 randomization looking at early TAVR versus medical therapy alone, with extensive follow-up and a primary endpoint that includes death, stroke, rehospitalization, and change in KCCQ scores. This study, I think, will again be an exploratory study that helps us to understand how we manage moderate AS, which you know by guidelines, there are almost no recommendations for treatment using procedures. Well, there are many at-risk predictors of moderate AS. I mentioned some of them: a low ejection fraction, severe cardiac symptoms is another, but there are several others, including atrial fibrillation and various echo findings like low stroke volume and severe diastolic dysfunction. And we use these now to construct 2 additional moderate AS clinical trials. The Progress trial, which is in a balloon expandable TAVR system, which is 750 patients already fully enrolled, looking at the SAPIEN 3 TAVR versus clinical surveillance in moderate at-risk aortic stenosis, looking at clinical follow-up, which will extend out to 10 years, and another trial, the Expand TAVR 2 trial, which is equally important and involves at-risk moderate AS patients. So we're trying to identify the population of AS, moderate AS, that has features that would be amenable to preemptive earlier treatment. So this is a concept that we feel is important. And if we look at aortic stenosis and think about it as not just the grade of hemodynamic severity on the vertical axis, but also the stage of cardiac damage on the horizontal axis, the only area where we have true level 1 guideline recommendations for aortic valve replacement is a relatively small segment of those patients that have severe hemodynamic stenosis. We now have many trials that are ongoing that will give us more evidence about how to expand that treatment to certain other populations. So I think we're beginning to understand within the spectrum of aortic stenosis how to better apply some of our new therapies. And finally, what is this concept of downstream considerations? Well, I mentioned some of the things before we do our procedures with aortic stenosis. I want to again mention there are many concepts that we need to understand to treat the patient after the procedure. The first is understanding how durable these valves are. Within the Valve Academic Research Consortium, we came up with a standardized definition of bioprosthetic valve durability. This is a very complex slide, so I won't go through it obviously, but it gives you a quantitative framework, a roadmap of how to diagnose durability. So a lot of the confusing literature where durability is based upon largely clinical parameters is now standardized, and this is critically important. Using these kinds of techniques we've already looked, and this is with definitions that are slightly different, but still quantitative serial echoes, and right now we have some evidence that structural valve deterioration at 5 to 8 years is pretty low with the 2 major TAVR systems, and bioprosthetic valve failure, which includes clinical parameters, is equally low. But these are prospective, non-randomized, small series, so it gives us some confidence, but it's not long enough, nor is it in enough patients. We did an analysis in the Partner 2 trial, the first one using the VAR3 definitions, and demonstrated that TAVR versus surgery was about the same with respect to 5-year bioprosthetic valve durability using these quantitative analytic techniques. And similarly, work's been done with the self-expanding bioprosthesis, demonstrating again that TAVR was at least as good as surgery, looking at the 5-year time point. Now, we're concerned about this because what we're seeing in clinical practice is that in patients under the age of 65, we have very little TAVR data in younger patients. Already in the United States, that almost 50% of these patients are being treated with TAVR, which is increasing dramatically as surgery is decreasing. So unless we understand how durable these valves are, then we will not be making good clinical decisions for our patients. So we looked at the 5-year data from the Partner 3 trial, which I showed you before, which did demonstrate durability of the clinical endpoint out to 5 years of death, stroke, and rehospitalization, which did demonstrate durability and stability of the hemodynamic endpoint, looking at mean gradient and valve areas. and also showed, again for the first time, that bioprosthetic valve failure to 5 years was now similar between surgery and TAVR. And we can look at this in the various components of bioprosthetic valve failure, but this gave us the beginning of confidence. Now, obviously, we need to follow this out to 10 years, and there's similar data with the Evolute low-risk trial, now with a 4-year analysis that was also presented at TCT by Dr. Michael Reardon. So this issue of bioprosthetic valve durability we think is important. It's going to impact us in the future, and hopefully we'll have better heart valve platforms in the future, because bioprosthetic valve failure, at least in the TVT registry, has been a big problem, certainly in surgical valves, but now we're beginning to see it in transcatheter valve failure. And this is a model that we've done forecasting what will happen, and by 2027 we predict that there'll be a larger number of redo TAVR procedures than TAV in surgery procedures due to the increasing numbers of patients with bioprosthetic valve failure. So the current valve market, which is about a $6 billion market globally, in the next decade will double, but the number of valve-in-valve patients dominated by redo TAVRs will increase by at least a factor of 6. So we need to deal with this issue. We feel that a lot of this has to do with the material science, and there are many new areas that are being looked at to improve valve leaflet technology, and I'll mention some very quickly. This is a resilient valve, which is a new form of stable capping of the aldehydes and glycerolization, which has been demonstrated in early studies to suggest improved durability with dry leaflet storage. It has now been incorporated in 7 valve platforms using the Edwards surgical and transcatheter valves. This is a different concept called Dur-AVR, which is a single-piece native-shaped biomimetic design that has been taken into clinical trials, very low profile, a balloon expandable version that has completed an early feasibility study and is currently planning a pivotal clinical trial. The early data from the EFS study is striking, with valve areas of 2.4, gradients less than 10, and a Doppler velocity index of 0.71 after treatment using an echo core lab analysis. And finally, this is the Foldax technique, making synthetic heart valves. This is a fully robotic manufacturing technique with no labor-intensive hand sewing of valves, small efficient robotic pods that can be made in various geographic locations to be able to reduce synthetic surgical and transcatheter valve systems. This is already in development, and the most important clinical work has been done in India in surgical aortic and mitral valve patients. So the polyurethane polymer that we're all familiar with has now been developed into a siloxane polyurethane, a super polyurethane, and has now been formulated in surgical and an early version of a transcatheter valve. These synthetic heart valves have higher tensile strength, tear strength, and low cyclic creep, and are meant to be one valve for life. So the early data, much of it coming out of India, will help us to understand if this new leaflet material is going to make a difference in the future. Finally, what about medical therapy for aortic stenosis? We understand the pathophysiology of aortic stenosis, the initiation phase, the issues relating to lipid infiltration and inflammation. Then, of course, the propagation phase with calcification and osteogenic differentiation. At the same time that we see LV changes of hypertrophy, interstitial fibrosis, and then replacement fibrosis. But there are no known proven medical therapies to slow or prevent the progression of calcified aortic valve disease. In addition, we believe that, forgetting about the progression of calcific aortic stenosis, many of these patients have LV remodeling that leads to heart failure after we treat them. So it's important for us to consider the residual risk from heart failure, largely associated with cardiac remodeling and irreversible injury, must be a treatment target. So we have been working with our heart failure experts to try to understand if we can start applying new ways to manage patients during the so-called latent phase and after treatment in those patients that already have signs of LV remodeling. So the medical therapy is targeted towards the ventricle to protect the pressure overloaded heart while AS is progressing, and to augment LV recovery after AVR. And we're starting to use some very well-known drugs like SGLT2 inhibitors in interesting clinical trials, using a clinical trial methodology that is completely new and innovative, where we look at adaptive randomization, we look at platform trial methods, where we look at common control arms, a whole variety of techniques, including imaging endpoints, that we hope will give us an accelerated understanding if we can develop new therapies to be able to both manage the progression of calcific AS and treat those patients with signs of cardiac damage. So to conclude, if we look at this schema of how we manage patients with aortic stenosis at the various stages of development, we think that this multi-drug precision medical therapy approach will have validity over the next 5 to 10 years and will be integrated into our thinking of how we manage patients once we can diagnose them earlier at a pre-symptomatic phase of their disease, much like systemic hypertension. And that will be combined with the therapy trials with hopefully earlier preemptive treatment in the appropriate patients to give us a more holistic understanding of how to manage the lifelong of patients with aortic stenosis. So when my good friend Alain Cribier comes to me and asks me, what's now? What should we do? After that initial case done more than 20 years ago, I can respond to him with confidence that given all the things that I've tried to convey to you in the last 30 minutes, that there's lots more to be done, and we think that we can revolutionize the management of aortic valve disease if we all work together and adopt this more holistic approach of lifelong strategy management. Thank you very much.
Thank you, Marty. This is Dr. Anand Khanna. It's been a really amazing talk, and I believe everybody who is here from Southeast Asia and other places of the world